The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
Could fewer hours at work lead to greater productivity overall? That's what proponents of a 4-day work week say. Tonight we'll find out more and ask whether that could be the next big workplace disruption made viable in the wake of COVID-19. Then, on this World AIDS Day, we'll find out about treatment breakthroughs and 4 decades on, how perceptions around the disease have evolved. It's Wednesday, December 1st, and that's tonight on The Agenda. On a dime, during this pandemic, companies that could transitioned workforces around the world to remote work. It seemed impossible until it wasn't. Now, as employers face labor shortages and trouble retaining talent, another idea that once seemed impossible is getting some attention. The 4-day work week. With us now on whether it's an idea whose time has come. Literally, furthest from our studio, as in halfway around the globe, 18 hours ahead of us in Auckland, New Zealand, there's Andrew Barnes. He's the founder of the investment firm Coulthard Barnes and author of The 4-Day Week: How the Flexible Work Revolution Can Increase Productivity, Profitability, and Well-Being and Help Create a Sustainable Future. In Waterdown, Ontario, near Hamilton, Parisa Mabubi, Senior Policy Analyst at the C.D. Howe Institute, and in Midtown of the provincial capital, David Zweig, Associate Professor of Organizational Behavior and HR Management at the University of Toronto's Rotman School of Management. And let me just say, I'm just old enough to think it's absolutely beyond incredible that we're coming from New Zealand, which I know for people who do this all the time is nothing. But anyway, Andrew, welcome to our program and to our other two guests as well. This is pretty cool that we're coming from somewhere where it's tomorrow already. Anyways, Andrew, if you would, start us off by giving us the overview of what you have in mind.
Well, thank you, Steve. What we talk about here is a 4-day week, or I use the phrase 100-80-100. What that means is we pay people 100% of their 5-day pay. They only have to work 80% of the hours, but we do that provided we get 100% of normal 5-day productivity. And that was the policy that we introduced in my business, Perpetual Guardian, back in 2018. And this is the movement that's now, flowing around the world, accelerated post the pandemic. So that's what we're talking about: reduced hours working, and some companies actually close for a day. In our case, we don't.
How well is it working, in your judgment, at your place?
Well, what we did is we were very lucky. We actually brought in a couple of universities to do some research alongside our initial trial and then do some follow-up. We found that our staff engagement scores, that's empowerment, enrichment, loyalty, those sort of scores, we found that those scores went up 40%, 40%. Stress levels dropped 15%. More people said they were better able to do their work working 4 days rather than 5. But critically, our productivity went up 25%.
And how do you explain all of that?
Well, I have the Canadians to thank for it, frankly. Way back in 2017, I read a series of articles in the UK Economist magazine. And they were talking about British productivity, and then they were talking about Canadian productivity in a couple of surveys. The survey said that the Brits were only productive for 2.5 hours a day. And in this particular survey, they said the Canadians were only productive for 1.5 hours a day. And I thought, why is that? Is that happening in my business? In other words, do we have a lot of busyness when we have people at work doing things that are either not work related or doing things that are not that efficient when you think about output? And that prompted me to say, well, is there a better way to do it? And what would happen if I did a deal with my staff and said, actually, I'll give you an extra day off if you can, work more efficiently. Think about what you will stop doing as well as what you are doing. And so that we can deliver that productivity in a 4-day week rather than a 5-day week.
We'll come back to productivity a little bit later, but let's get some feedback first of all, now that you've set the table on this idea. Okay, Parisa, first of all, let's just make sure we're all talking about the same thing here, because there is something, I guess they call it the condensed week, and this is not that. Do you want to make us understand the distinction?
Yes, absolutely. What we are talking about is people work for 4 days, but they also add fewer hours. So there is no change in the number of hours per day people spend at work. It's going to be the fewer days that also they work. So they have to complete the work within 4 days and similar hours per day as before.
Okay, you've heard the numbers that Andrew just shared with us. Do you see a downside in the kind of workplace structure, the 4-day week, that he's put in place where he is?
In my opinion, that would be wonderful if we can finish the work and remain, become more productive. If that would be an ideal situation to have a long weekend, basically throughout the year. But the problem is that whether this is something that would be possible in all organizations, whether this is something that would be sustainable, whether we are going to consider the needs of different organization and even people. Some people may not be able to deliver the work within 4 days and they need to spend extra time to finish the work. What we can do about those people?
Well, let's ask Andrew. Is this something that you think can work across society, or clearly it's only going to work in some places but not others?
No, Steve, it can clearly work across all industries. The key is you've got to ask your employees how you're going to do it. But the thing that often happens is people say to me, well, Andrew, it wouldn't work in this or it wouldn't work in that. The reality is that somewhere in the world you will find there is a manufacturing business, there is a health business, there is an educational establishment that is doing the 4-day week. And the key thing here is that we're not talking about, an organization closing if it can't. We don't. We have to work a 5-day week. So what we do is we allow people to pick the time off that they need and that's important to them. So I think you can tailor this to any industry that you want. And I think the evidence suggests that that's the case.
Meaning it's not just Monday to Thursday and then you're closed Friday. Everybody, if Wednesday is a better day for somebody not to come in, that's the day they take off. Is that how it works?
Well, absolutely. Look, we used to have a young woman whose husband was a chef, and he had Tuesdays off. So she wanted to take a Tuesday off so that they could spend a day together. I said used to have a staff member because now she's taking maternity leave. So, in many ways, that gave us arguably our first 4-day week baby. But we have people who take a couple afternoons off if that's what's important. We also have staff who come in late or come in early and go home late. And they will do that depending on what their childcare needs are. And so we enable our staff to reduce the hours, but taking the time out that's important to them. And the organization remains open.
All right. David, put your Rotman hat on and
Sure.
Tell us what you think about all this.
And I think the idea of a 4-day work week is great. There's a lot of constraints around how it's implemented and how effective it can be, and there has to be a lot of flexibility. This is not a new idea. In fact, when I was doing some research for the show, I found that, this idea of a 4-day work week popped up in the 1950s, and people were doing research on it, in the 1970s, and it was predicted then that it was going to be this big new thing. I think what's turbocharged all this discussion of a 4-day work week is obviously COVID. It's thrown a Molotov cocktail through our office windows, and it's making us question everything. And there's no doubt that people want more autonomy, they want more flexibility, they want more freedom in choosing how and when they work. And this idea of a 4-day work week can take advantage of that desire. Now, the concern I have is obviously it has to be to work for everyone, but we also have to see whether the positive effects last over time. So, people often experience regression to the mean with their affect and with their behaviors. So we have to see whether this actually does result in long-term productivity gains or long-term benefits in terms of engagement and satisfaction.
Okay, hold off on that, whether it's good for the long run aspect of the argument for a second, because I want to circle back to something you just put on the record a second ago. You say they looked at this back in the 50s and in the 70s. So clearly there are management people who have been curious about this enough to study it. Why do you suppose that in all of these intervening decades, it's never really been tried?
Well, it has been tried. It's just, for something like this to really work, you need large-scale adoption because you're asking organizations to change the way that they do business in a sense. And it has to be a very flexible model, as Andrew said, because there's so many different constraints and so many different issues to deal with. When you're implementing a system like this, for it to be successful, it has to be incredibly flexible. So, what if you have a team and you've got a member of the team who decides they want to take Tuesday off when the rest of the team decides they want to take Fridays off? How does that work? So all of these questions need to be addressed and answered for this to be successful. So that's probably why we haven't seen wide-scale adoption yet. But COVID has been such a big trigger for massive changes in the workplace. It's a good time for something like this to really take hold.
Andrew, how do you get around the conundrum that David just described?
What we do is that we put the challenge to each of the teams. So I don't actually schedule anything. What I say is the key issue is that we need the same level of productivity, or preferably better. We also need to make sure that customer service standards aren't impacted. So each team understands that they need to be able to continue to service the clients appropriately. Now, after that, it's up to each team leader, to schedule who takes what time off when. Now, we don't have a situation everybody takes Friday off or everybody takes Monday off, because then that doesn't work. So if you want a Friday off, maybe you'll get Friday this week, but maybe next week you won't. You'll have to take a different day. The only thing that is consistent is where we have, as I've said, parents of kids who are at school, they probably want to work a 5-day, but they want compressed hours. We leave it to the teams to sort that out. I've never, ever had to intervene since we put this in place, what is now over 3 years ago.
Parisa, I wonder if you asked your own employer, the C.D. Howe Institute, this is something I think we should try. What do you think the reaction would be?
I'm not really certain about that, but I would say giving flexibility, that would be very helpful. This is what workers would need, even at the city, how having flexibility in terms of what time to work or from where to work, really important. But in terms of reducing the hours, that my concern is that, for example, if a work needs to be done in collaboration with other workers, if someone doesn't want to be available in a specific day, how that collaboration would work and how the work can be done. That's my concern about that. But of course, giving flexibility to workers would be increase productivity and satisfaction, and it would be something that even we have seen before COVID time and during the COVID, that hybrid model of work from home and also a combination with being at the workplace is going to be very beneficial for everyone.
Well, let's pick up on that productivity puzzle right now then. And we're going to share some numbers. And Parisa, these are your numbers provided to us on the issue of productivity. I'm dying to have people take a guess what they think is the most productive country in the world right now. So I guarantee you nobody's going to get it. Number one is Luxembourg. GDP per hour worked $93.40. And the average work week in terms of hours is 29. Now let's go down the list. Number 2, Ireland. Number 3, Norway. Number 4, Belgium. The United States clocks in at 5. Then we'll skip a bunch and go further down the list because that's how far you got to go to get to us. Australia, United Kingdom, Italy, Spain. Yes, there we are. Number 18, Canada. Well down the list, $50.90 GDP per hour worked, 32.8 hours for the average work week. All right, Parisa, come in here and tell us, in your view, what story do those numbers tell?
So first of all, I just want to mention that the data is from OECD and it's for 2015. What we see here is that for it obviously highlights the productivity issue that Canada has been faced especially since 2000, because the productivity growth has been very low for Canada. It never, on average, never went above 1%. And the ranking is 18 among developed countries and OECD countries. But one thing that I like to highlight from that table is that there is no specific connection between hours of work per week and also productivity. For example, in that table, Ireland or United States, they have higher productivity, but also average of hours work per week is higher than Canada. So there is no specific correlation here between, if we are going to reduce hours of work, whether we are going to gain a lot from that.
Well, I actually wanted to pick up on that with Andrew because, in fact, Ireland is nearly twice as productive as Canada, and yet they work a longer work week. Not by much, 33.5 versus 32.8 average hours. What's the story there, Andrew? How can they be so much more productive when they work basically the same work week we do?
Well, actually, the problem with the Ireland and the Luxembourg numbers are that both of those countries are low-tax jurisdictions, which actually flow through their economies revenues and outputs which aren't actually really generated in their countries. So those are a little bit of an anomaly. But it does raise the point that quite clearly there is no direct link between your output and the hours that you work. And in fact, if we go back to Keynes, years ago was saying that actually now we probably should be working 15 hours a week in order to get the appropriate levels of output. So what we've got to look here is that it isn't linked to the amount of time you work. What the key point here is about what you produce in each hour and how do you improve what you produce in each hour. That's the challenge we've got to address. Time is a lazy surrogate for output and productivity and efficiency.
And Andrew, for how many years have you been doing it this new way with the 4-day work week at your company?
We started at the beginning of 2018.
2018. Okay, so David, tell me this. That's about 3 years worth of data, 3 years worth of experience upon which to make a judgment. Andrew tells us the productivity at his company's gone up 25% since they went to this. Is that enough time to be able to conclude, yeah, this works? You get more productivity when you do it this way.
Listen, it's one company and it's positive and certainly it's going in the right direction. But what you have to look at beneath all of this is that Andrew is offering his team a hell of a lot of flexibility and autonomy, and that's what people want, right? So they're responding to all of the flexibility and autonomy they have to decide how they structure their own work, and in response, they're actually keeping their production levels very high. So we're seeing this, everywhere in terms of the Great Resignation and everything, the post-COVID fallout, although we're not post-COVID yet, in terms of people wanting more of this autonomy and flexibility. And we're also seeing organizations recognize that they really do have to pay attention to their employees' mental health. It's why you have, big banks increasing, mental health benefits to $10,000 a year. It's wonderful, but they've also calculated that it's easier to do that or more cost-effective to do that rather than lose employees to burnout. So anytime you give employees more autonomy and more flexibility, which is what they want, you're going to get better outcomes. And so that's why if you're going to implement a 4-day work week, having a very flexible policy around how people organize their time is going to be very important to success.
Parsa, do you believe now that all of these questions, thanks to the pandemic, are in the air about how people work, where they work, how much they want to work, what they feel their labor is worth, do you think that this will kickstart a greater sense of urgency among employers to consider this idea?
It would be possible. The reason is that currently many employers are facing retention challenges, to be able to keep their employees in place. And but at the same time, we are also facing labor shortages. So employers have difficulties fill the vacant jobs. So this is really important to satisfy workers, to increase workers' retention. But at the same time, this is also, we need to think about flexibility. So flexibility is really important, but we also, at the same time, we want to maintain high productivity. We want to make a sustainable, productive workers. And we have to think about other aspects. For example, inequality. What does it mean if some workers, they are able to have that opportunity, but others, part-time workers, those hourly paid workers, they don't have that opportunity to benefit from that arrangement or flexibility. Of course, some workers would benefit from that, and that flexibility would satisfy them. But we have to think about other organization, the type of organization, and teamwork, whether it's going to be possible to complete a job when some teamwork is necessarily part of the work.
Let me do a quick follow-up with you. How about the age of the workforce? For those who are older in the workforce, what do you think the impact of a 4-day work week would be?
So I believe that would be actually something beneficial for them. What we want is to encourage people to postpone their retirement. And this is really important for our workplace. So if they don't need to work 5 days a week per week, so that would be something that they would benefit from, and they may encourage to stay longer in the workforce. But at the same time, because we are facing population aging, and also in the long term, in the next 15 years, the number of people exiting workforce would be significantly high. That would pressure on workforce. So we need to think about how we can address labor shortages, and also in terms of job training. So young people coming to the entering the labor force, or immigrants entering the labor force, they need some sort of job training in the beginning. But if we reduce the number of days people at work, so that would be also affected, and we would have some challenges in terms of on-the-job training for young individuals entering labor market, while a large number of older people exiting labor market.
Well, now that's one of the things I wanted to follow up with David on, because if one of the effects of a 4-day work week is to those who are over 60, they say to themselves, well, you know what, if it's only a 4-day work week instead of 5, I think I'm going to work a little longer. Could that have a perverse impact on getting younger workers into the workforce sooner?
I mean, it can. I mean, with the labor shortages we're facing, it's not, that big of a problem, I don't think. But, I'm not a labor economist, so it's not really my area of expertise. But, I'm getting older. I would happily take a 4-day work week. I'd take a 3-day work week, as long as I could get all of my work done. But so I can see this being a benefit to, at every stage of someone's life, there are benefits to having more flexibility around how they manage their work. Whether you're a new entrant to the workforce, or whether, you're a new parent, or whether you're an older employee thinking about retirement, there are benefits to this throughout the career span that match up with people's life stages.
Andrew, in your judgment, if the numbers all line up so positively for this idea, do you think now is the moment when it actually may catch on?
Absolutely, Steve. I think that, it was mentioned earlier, we had this sort of bomb thrown into our world of COVID. And who'd have thought that you could run a multinational from your kitchen table? But now you can. And so what we've got is a complete change. We've got not just employers saying, can we do things differently? We've got employees all around the world. I've spoken in 97 countries worldwide on this topic. And all the surveys that we're doing on the 4-day week are indicating that 80–90% of people want to have a 4-day week. So this is why I maintain that this is an idea whose time has come. But it's not just the time has come for it. We've now got the technology to enable us to do it. And that's the big change.
I guess one of the things we have to keep in mind is that there's nothing, the fact that we have a 5-day work week right now, it did not come down from Mount Sinai. The fact is we used to have a 6-day work week, and I guess about 100 years ago, enough unions made a stink and it became a 5-day work week. Andrew, in your view, is this just sort of this is the typical cycle of the direction in which we should be going?
Yeah, absolutely. I mean, people credit Henry Ford with the 5-day week. What effectively he did is he changed his production lines to work on 5 days. Part of that was actually to increase the amount of leisure time for his workers so they'd buy a Model T Ford. There is, as you say, absolutely no science around it. And what we are now saying is that the improvements in productivity that we've seen in the fourth industrial revolution are now such that we're not actually sharing necessarily the benefits of that. The great thing about a 4-day week is it starts to share those benefits with the whole of the workforce, rather than concentrating the benefits on a few highly paid individuals.
And just finally, Andrew, one last question. The role of automation in the shorter work week, what is it?
Well, actually, I think this is one of the strengths of the 4-day week, because actually, to be honest, in my business, it isn't automation. A lot of this is eliminating busyness, things that you do that are work avoidance. And the best example of this is Microsoft in Japan, that just basically reduced the amount of time and the amount of people in meetings and got a 40% improvement in productivity. But I think the key point is that if you give people more time, then they actually have more time to invest in themselves. And it was one of the key points that was raised, I think, by Parissa, about this issue about training people and the need for education in the face of things like AI. You give people more time, they've actually got more time to invest in themselves. And especially as businesses change and our kind of economies change, the 4-day week can be a tool that assists that process.
That's Andrew Barnes. He's the author of The 4-Day Week. Joined us from Auckland, New Zealand, Parissa Mahboubi from the C.D. Howe Institute, David Zweig from the Rotman School of Management at U of T. It's been a great pleasure having all three of you on our program tonight. Many thanks.
Thank you.
Thank you. "40 years ago, the first few cases of what would come to be called AIDS, acquired immune deficiency syndrome, were reported. Since then, more than 36 million people have died from it, and more than that live with it around the world every day. Treatments and hopefully a vaccine are essential to ending that epidemic. Let's get the latest on all of this from Dr. Sharon Walmsley. She's Director of Clinical Research at the Immunodeficiency Clinic at Toronto General Hospital and a professor at the University of Toronto's Department of Medicine, who joins us from Hospital Row in the provincial capital. And on the Danforth of the capital city, Dr. Daryl Tan, infectious diseases physician, clinician scientist, and director of the University of Toronto's Clinical Research Unit on HIV prevention. And it's great to have you two with us on this World AIDS Day. I want to start here. Sharon Walmsley, let me start with you. How much of what we have learned about HIV over the past few decades, in your view, has served us well as it relates to fighting COVID-19?
Well, Steve, I think you raise a very important point. And when the COVID pandemic hit, who did they turn to but those of us who've dealt with the HIV pandemic? And as part of dealing with that pandemic, we learned important things about viruses that were causing unknown disease, our concern about contagion, our concern about who was at risk and how to manage it. And many HIV treating physicians stepped up to the plate and said, how can we help with the COVID pandemic to help design the clinical trials, the management of patients, the isolation precautions that might be necessary to fight this new disease.
All right, Daryl Tan, let me follow up with this, because you focus on prevention of HIV. Have those lessons helped in preventing the spread of COVID-19 in your view?
Yeah, Steve, I think they have in a lot of different ways. I mean, on a certain level, a really important contribution that our understanding of the HIV pandemic has made to the COVID response is simply understanding how infectious diseases like both of these viruses tend to propagate in populations. The risk of acquiring both HIV and COVID-19 is not actually equally distributed in our society. A lot of these epidemics tend to move along fault lines in our society, such that those who are systematically marginalized by structural forces of, racism, poverty, discrimination, stigma, etc., tend to be the very folks who are overrepresented. Whether we're talking about gay, bisexual, other sexual minority men, or people who use drugs for the HIV pandemic, or the elderly and migrant workers and people who are in marginalized populations that have faced systemic racism and therefore have skepticism about vaccines. There's a lot that we've learned about how these illnesses transmit through populations that have really informed how we should target our prevention efforts.
Let me do a quick follow-up with you. Is it fair to say then that both of these pandemics have been in some respects very unfair in as much as they seem to pick on the most vulnerable among us?
I think that's a nice way to put it. Absolutely. And I think that it reminds us that our approaches need to be informed by that. We can't simply assume that everyone has equal access to information and treatments and prevention tools. We need to, in many ways, work extra hard to bring the tools that we know work to those who we know can benefit most. And we need to be prepared for the fact that those same communities may actually be quite skeptical and apprehensive about authority figures reaching out. So it's not quite as easy as sometimes one would expect it to be if all things had been, in fact, equal.
Sharon, let me set up this next question to you by sharing some numbers with our viewers and listeners. And these are very stark numbers. 70 million people have acquired AIDS. More than 35 million have died from it. Today, around 37 million people live with HIV, that's worldwide, and 22 million are in treatment. Millions and millions of people have been affected by this. We got a vaccine for coronavirus, lickety-split. And here we are 4 decades later and still no vaccine for AIDS. Why not?
Yeah, that's for all of us who deal in the HIV world, that's been a major source of frustration and clearly a major way to impact a pandemic or impact an emerging infection is to develop a vaccine. So, in HIV, in the early days of the epidemic, a lot of our focus was really on treating people. When people were first diagnosed with having HIV, that was a life sentence. They were going to die in 6 months. And so much of the research at the time was really on how can we treat people and maintain health. And in the early days of the epidemic, there were some candidate vaccines. They weren't very successful, and there was not a lot of resources being put into developing vaccine for HIV. So for many years, progress was extremely slow, and there was a few candidate vaccines for HIV. They were not very effective, and without resources, it's hard to move along. And so when COVID happened, there was a lot of money got poured into vaccine very quickly. There was a number of people on the front lines and a number of vaccine companies that have been developing these technologies in the back burner, and they were ready to develop them up. And the money was there, and the will was there to develop these vaccines, and that's why they happen so fast. On the other hand, HIV is a different virus, and the HIV virus actually integrates into the cells of the host, and that's what makes it tricky. And the HIV virus also mutates a lot. We've heard a lot about COVID variants. Well, HIV virus changes itself a lot too. And the problem is a lot of the vaccine research happened in the developed world, whereas the HIV pandemic is in the developing world, and the vaccine that is developed in our country may not be effective against the viruses that are in Africa and other parts of the world. So there are differences in the will to have that vaccine happen, in the resources to have that vaccine happen, but the viruses are very different, and they're very different in their mechanism of action, and the HIV virus has proven to be a very tricky thing for us to develop that vaccine.
Daryl, let me follow up with you in this, and I'm really not trying to put words in your mouth here, but I remember when AIDS happened. I remember in the early 80s when it started, and a lot of people said, oh yeah, that's that disease that those people get. How much of that thinking has delayed an international effort to find a vaccine?
Well, I think there's certainly some elements of that thinking today, Steve. I mean, we all it took a while for the global response to really recognize how global the COVID-19 pandemic truly is. And still today, in the last several months, I think here in Canada, we've been very fortunate to have a successful, for the most part, vaccine rollout, and that's allowed many of us to start to live our lives in a way that was more similar to prior to the pandemic starting. And yet, we've seen that the COVID-19 pandemic rages on all over the world, and a lot of that has to do with not necessarily thinking that COVID is a problem for other people, but rather it's a symptom or a function of us not really recognizing that this pandemic is a global pandemic, just like HIV was, just like so many other infectious diseases are. And really none of us are safe until all of us are safe. It sounds a bit trite to say, but it's really true. The emergence of this Omicron variant with SARS-CoV-2, the virus that causes COVID-19, is a perfect illustration of that. Much of what we recognize allows new variants of both viruses to emerge is ongoing spread, because the viruses can continue to mutate and transmit between people unchecked. If we had been more successful at rolling out and politically prioritizing the true equitable global rollout of prevention tools like vaccines right from the get-go, we might have seen much more controlled progress with COVID-19 that could have curbed the emergence of new variants. It could still happen, of course, but it may not have been as dramatic, as fast. And I think it reminds us of just how global these pandemics can truly be.
Mm-hmm. Sharon, let me ask you a bit more about your work. Do I have this right that your focus is on the women and the elderly in particular who are dealing and living with HIV?
Absolutely, Steve. And I think when a lot of the world, and I think what you've been alluding to, thinks about HIV, they think about gay men. But no, HIV does not only impact gay men. And my focus has always been on women, that women represent half of the world's pandemic of HIV. And over the years, a lot of the research has focused on gay men and has not been specific to women. So I've tried to be their voice. I've tried to make sure that the clinical trials involve enough women so that we can understand the impact of this virus. And now, and my research, from the day one has followed the pandemic. So initially we were looking at opportunistic infections, and then we were looking at the treatments. But now people, because of our advances in treatment, are surviving into old age. And so the first wave of people infected by HIV in Canada are now in their 60s and 70s. So we've developed a new study to look at HIV in the aging, because this is the first generation of persons to have aged with HIV. And part of the problem is many of these people 20, 30, 40 years ago, they thought they were going to die. They gave up their life insurance policies. They gave up their jobs. They lost many of their friends and families. And so they're living alone now and in isolation and without resources. And we really need to look towards their future and how they can age well with HIV.
It kind of never occurred to me, but I guess if you do the math, are you telling us that there are women in their 80s today who are living with HIV?
Yeah, during the second month of the pandemic, I had 2 women, new patients in my clinic. They were both over 80, newly diagnosed with HIV.
Amazing. Daryl, you focus on prevention, and we know the most obvious solution, or the most obvious way to make sure you don't get HIV is, if you're having sex, have safe sex, use a condom. Now, besides that, what are other ways that you're looking at, other options for preventing the contraction of HIV?
Yeah, Steve, it's a great question, because I think a lot of folks are familiar with the traditional behavioral approaches to HIV prevention, which definitely include things like condom use, as you mentioned, with respect to sexual transmission of HIV. But what many folks don't realize is that actually a lot of the biomedical tools that we have developed over the last decade and more are actually extremely successful at preventing HIV as well. So one of those tools is simply treatment. Treatment of HIV itself in folks who are living with HIV is associated with a decrease in the virus in the person. And when that viral load goes down to undetectable levels, really, really low levels, that in itself is associated with a 0 risk of transmitting that virus to a sexual partner, even if no condom is used. And that's a dramatic change compared to what we knew just several years ago. So that's one important tool. But another one relates to the use of many of the very same medications that we use for HIV treatment for prevention purposes. And in particular, a lot of my work focuses on something that we call PrEP, which stands for pre-exposure prophylaxis. This refers to the use of certain anti-HIV medications on an ongoing basis. Sometimes it's used on a daily basis. Sometimes it's used just around the time of an exposure, such as around the time of having sex, by people who are actually HIV negative, but who recognize that they're at an increased risk of acquiring HIV. And by using these medications on an ongoing basis, we can actually reduce those people's risk of acquiring HIV to almost 100% if they're using them regularly. And this has really revolutionized our approach. Globally, there have been a number of jurisdictions that have really embraced PrEP and similar approaches, I would say more than we have in Canada so far. And they've actually been much, much more successful as a result in actually curbing HIV infection rates in their jurisdictions, really seeing those rates come down. And so it's something we really need to be publicly promoting as a healthy choice, as a smart choice, as a safe choice, and making much more available to those who could benefit from it.
Yeah, Sharon, I don't want to oversimplify this, but I guess the reality is, if starting today, everybody practiced safe sex, and people used, for those who use drugs with a needle, if they made sure that it were done in a safe setting, let me put it that way, nobody else need get another case of AIDS. Isn't that right?
Yes, in theory, we could eliminate this infection through practices that prevent transmission. The problem is people are people, and people often don't recognize they're at risk, and that's the problem. If people don't recognize they're at risk, they don't go out and get tested, then they can be the source of virus to other people. And in fact, even today, of people who newly present with HIV, still, a good quarter of people present very advanced in their HIV, didn't recognize that they were at risk, didn't go and get tested. And so that's the difficult part, is having people realize that, hey, I could be at risk.
Now, I know we touched on this earlier, Daryl, but I want to circle back because I'll just read it here. The theme of this year's World AIDS Day is End Inequalities, End AIDS, End Pandemics. 3 very worthy goals. Let's just pick that apart a little bit. End inequalities. What is that a reference to?
Well, I think it's a reference, Steve, to a number of different things that allow these epidemics to propagate. So number one are stigma and discrimination. I think these are really powerful forces that prevent folks, as Sharon was saying, who may benefit from testing, from treatment, from prevention technologies, from even accessing it in the first place. And I, in my practice, see this as a challenge all the time. Folks delay seeking care because of the discrimination that is associated with this virus unnecessarily. But another important set of inequities relates to just the sheer dollars and cents, just the socioeconomic inequalities. And we here in Ontario, in most of Canada, continue to live in a society that is very proud of its universal healthcare system. But what we fail to recognize is that we don't actually have truly equitable access to medications, both for treatment and for prevention. The cost of these treatment and prevention tools, as successful as they are, can easily add up to hundreds or thousands of dollars per month, or can add up to significant co-payments and a lot of bureaucratic paperwork that unnecessarily impede access to these life-saving and health-preserving treatments. So we really need to fix that problem, because I think that those economic inequalities are really, really core, in addition to these the social factors like discrimination, at perpetuating these pandemics.
And Sharon, in our last 20 seconds, how close do you think we are to a vaccine, finally?
I don't think we're there in my lifetime, unfortunately. So I think we really need to continue to focus on improving our treatments, making them easier for people, making them available for people, as Daryl said, and making them more acceptable. And I think where treatment is going is really into some more of these long-acting compounds that people might be able to take once a month, every 6 months, maybe once a year, for both prevention and treatment. And I think that those will go a long way for helping us keep the virus level in the population under control.
Gotcha. Sharon Walmsley, Daryl Tan, really good of both of you to join us tonight here on TVO. Thanks so much.
Thank you, Steve.
Happy AIDS Day.
In the early days of the AIDS epidemic, the disease swept through communities, leaving a trail of death and fear. That's no longer the case in most industrialized countries, but too often the stigma of HIV lingers, and that can hamper efforts to prevent disease transmission and put an end to the epidemic. With us now for a frontline view of what's needed, in Vaughan, Ontario, practicing psychologist Trevor Hart, who is also director of the Ryerson University's HIV Prevention Lab. Trevor, it's good to have you on our program tonight. How are you doing?
I'm doing very well. It's good to be here.
Before we talk about AIDS today, I'd like you to take us back. Take us back to the early 1980s. And of course, we're going to have a lot of people watching or listening right now who don't remember those days. They weren't around. And I want you to give them a sense of what the general population thought about AIDS at that time.
Well, it was a really different environment for a lot of people. They were afraid that this really was a death sentence, that they would get this virus and get sick and eventually die from the virus. It was a very scary time for people, and there was a time that people were feeling really apathetic in the general society about the people that were getting HIV. They didn't really care about those people who were getting HIV and would kind of hope they would go away. I was just chatting with somebody about this, about that history in the 80s, and some people in the general population were saying HIV actually was the cure of these people that we don't like.
Yeah, in fact, I remember well, it was often referred to as the quote-unquote gay plague, something that happened to other people that sort of polite society didn't need to worry about. When did those perceptions begin to change?
Well, I think that they haven't changed 100%. I mean, it was in 1996 that there was the advent of highly active antiretroviral therapy. Those medications changed HIV from a death sentence into something that is a chronic disease that people can live with. So that really changed the perception of HIV as a death sentence. But I still think that most people in Canada perceive this to be a gay disease. It is disproportionately found among men who have sex with men, but about half the people that are getting HIV to this day in Canada are not men who have sex with men. They're mostly heterosexual folks.
And how do they get it?
They get it by having sex, mostly. Mostly they had sex without condoms. And so there's that whole judgment that people have about people that have HIV. But that's mostly how people are getting it, is by having anal or vaginal sex without condoms, or if they're engaging in injection drug use and sharing needles with other people.
How do you think it is that 40 years later, and 40 years of, people who do what you do for a living, constantly putting out information that unsafe sex can lead to this, why is this still happening?
Well, I think it's still happening because people are not a big fan of using condoms. I think that's a part of it. And I think a lot of people right now see that the HIV epidemic, isn't that kind of over? Isn't that really something that has passed? Unfortunately, it hasn't passed. In fact, cases are going up in Canada as we speak and have been going up for the past few years. But I think there's a perception of it's somebody else that gets HIV, not me, or it's only specific communities. It's not anyone I know. And then there's also a concern that for some people, condoms, which is still the most common route for preventing HIV, that are not particularly attractive to some people. They're not as interested in using them. Most heterosexual people are using contraception if they need to use a method, but contraception is against pregnancy. It doesn't actually protect you against HIV.
Help us understand which demographic may be refusing to follow the facts carefully. You'd assume it's younger people who have no firsthand memory of life in the 1980s and 90s when AIDS really became a major factor on the healthcare scene. Is that in fact the case?
I don't think so. I think that the evidence is that it's people across the board. Younger people, older people, we're seeing some increases in HIV and sexually transmitted infections like syphilis or gonorrhea or chlamydia in elder care homes. So it's not unique to young people.
You say the rates are going up in Canada. How about in other Western nations?
Well, not uniformly. It's not inevitable that cases should be going up in Canada. While cases have been going up over the past few years by about a quarter, new cases in Canada, in the United States, which has a much less well-funded healthcare system, their new cases of HIV are going down by 8%, at least in the general population, in the same time period. And in the UK, across, I think, about an 8-year period, their cases have gone down by almost a third.
And what do you attribute that to?
Well, it's hard to say. But one thing I can say is that we know what methods are evidence-based, that are at the large public health level. And it's all about getting tested for HIV. It's about public health authorities actively pursuing HIV testing for folks who are more at risk for HIV. But even in the general population, it's about getting people tested. And when they get tested, if we find out that somebody is living with HIV, that we get them effective treatments. Because we know if people have effective treatments, then they will live long with HIV. And also, if we can get the viral load that they have suppressed, so it's so low that it cannot be transmitted to somebody else, that person also can't transmit their HIV, even if they do have sex or if they do exchange needles.
In terms of public health messaging, though, you know, it worked wonders dealing with the global pandemic we're facing right now. It worked wonders to say to people, you know, it might be a good idea to get vaccinated or you'll die. Do you think that's a good approach to take with AIDS?
I think that the fear-based approach does work. It works in the short term, but I think in the long term, it doesn't tend to work quite as well. That fear-based approach worked pretty well in HIV. When people were initially dying and didn't know what to do, or they were like, listen, people have to start wearing condoms. And condom rates actually increased specifically among gay and bisexual men. And they increased to a lesser extent in the heterosexual population. But it didn't last forever. Eventually, people do tend to tire of public health regulations, especially when it's not something that can be done very quickly, like a vaccination. And we're seeing this in the COVID-19 epidemic. We're seeing folks that are, even if they want to do it and they're going to do it, they're feeling a bit tired. They're feeling a bit exhausted by the social distancing. They're feeling exhausted by the mask wearing and about the anxiety that they're experiencing because of COVID-19. And for HIV, I think a lot of people they just would rather not talk about it. They're fatigued about hearing about HIV, especially during the COVID-19 epidemic. But even before then, they're fatigued and they kind of wish it would just go away, so they don't think about it.
Yeah, that doesn't really work, though, does it?
Unfortunately, it doesn't, as
No.
evidenced by our increasing cases in Canada.
Right. Well, let's transition here from your work as a researcher into this to your work as somebody with a private psychology practice who deals with patients who have HIV. Tell us what one of the most interesting things is that you learn from listening to your patients talk about their experiences with this condition.
Well, I'd say one of the most profound experiences is HIV stigma. So HIV stigma is the stigma of living with HIV. It's that negative label that's placed upon people because they have something that's socially marginalized in society. And so what we find is that what they're concerned about is not about, should I take medications? The folks that I'm working with who are living with HIV, they're taking their medications. Their concern is about HIV stigma. It's about, I'm the same person I always was. Will I be treated worse? Or what will I do when I'm treated worse by other people? And it is a big problem. People are judging people with HIV that something is wrong with them. They were dirty, they were bad, they were promiscuous, and that's a terrible problem. And what's of course ironic about HIV is you get HIV because you had sex and you didn't use a condom. And most people I know, that's actually how they were made. They were made by two people that did that exact thing, and it wasn't a bad thing at all, was it?
Well, I guess when you put it that way, that's a good point. What do you think it's going to take in order to get that stigma, which I think it's fair to say is less today than it was 40 years ago, but what do you think it'll take to get it to be even less still?
Well, yeah, I think it might be less than it had been previously, but I think a lot of it is about education. I think that we in Canada could be doing a much, much better job at rolling out HIV education and getting the organizations that do this kind of work, like they're called AIDS service organizations that do a lot of the heavy lifting on when it comes to HIV education and prevention, getting funding to them so that they can do this work in their communities. While simultaneously we're seeing increases in HIV cases in recent years, a lot of AIDS service organizations are complaining their funding is being cut over the past few years. And it is really quite a problem. If we want to see decreases in both HIV stigma and in HIV, we're going to need to fund the organizations that do that heavy lifting.
Let me give you the last word on this, Trevor, and that is, it is World AIDS Day, and I want to know what the correct word is to use as we commemorate, observe, celebrate. I don't know. You tell me.
Well, I definitely wouldn't say celebrate. It's a disease, and it's a disease that people are living with. And because of HIV stigma, I think that maybe commemorate is more appropriate. I think I'd be more likely to celebrate World AIDS Day when there's a period where there's no HIV stigma, where people with HIV are treated like people with any other kind of disease that is not stigmatized, when there are not new cases of HIV because people are finding ways to protect themselves through pre-exposure prophylaxis medications, which are the medications that HIV negative people can take to prevent getting HIV, or through condoms, and where people that are living with HIV can live long and happy lives with a good quality of life.
Sounds good. Trevor Hart, who is director of the Ryerson University's HIV Prevention Lab. It's really good of you to join us tonight on The Agenda. Thanks so much.
Thank you so much for having me.
And that is The Agenda for Wednesday, December 1st, 2021. As the discovery of a new variant made clear, we are not out of this COVID-19 pandemic just yet. Tomorrow, we'll do some fact-finding on treatments and drug therapies available for those who get sick. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.